Now, a patient 23-year-old presenting with history of urinary incontinence, especially when she coughs or say climbing upstairs, etc. So, how are you going to evaluate her?
Okay. I'd like to see this patient in my clinic, preferably have filled in a frequency volume chart. And on her attendance, I'd like her to have a urine dip, urine analysis if it's clinically indicated. I'd like her to have a post-voidal scan. And on her attendance, I'd like her to fill in an ICIQ SF urinary incontinence questionnaire. In history taking, I'd like to start my consultation by asking about her most bothersome symptom. I'd like to know the onset, course, and duration of her current complaint, whether she had any medication for this before or not. Then I'd like to assess the severity by asking about one, what triggers the incontinence, how many pads does she change a day, and as well as then I'd like to ask about her fluid intake, bowel movement, and then move on to the long-term medication she's on, as well as any surgical history of any relevance, including whether she has a number of deliveries and the method of delivery, and whether there were complicated or not. After taking history, I'd like to do a clinical assessment. After taking her approval and being chaperoned, start with abdominal examination, seeing if there's any palpable bladder, tenderness over the loins. Then I'd like to do a stress test, assess to see if there's any leakage, do a vaginal tone assessment, as well as internal examination in the lateral and the supine position using speculum, see if there's any possible prolapse. In the history taking, sorry, I forgot to mention that I'd like to ask about the red flag symptoms, including dysuria and hematuria. After I've done the clinical assessment, I will do a neurological assessment to see if there is any deficits suggesting her symptoms, and then also comment on the estronization and whether there's any signs of vaginal atrophy. And then I'd like to arrange for further investigations as indicated.
Okay, that's a good comprehensive one. The only thing is you have almost reached 2 hours 40 seconds. Not bad. Sometimes in this scenario you can still manage well. But please mindful, never cross 2 minutes in an opening gambit. I know it's difficult, but you need to work on that. You haven't uttered anything unnecessary or extra, but it should be less than 2 minutes so that you can go to that last mark 8 questions to push. How will you define stress urinary incontinence?
Stress urinary incontinence is the leakage on urine leakage on increase of abdominal pressure that which overcomes the sphincter competency.
Okay. What are all the etiology or other factors which can cause stress urinary incontinence in a woman?
That could cause
Causes, yeah.
Other causes that cause stress incontinence or any types of incontinence?
No, stress urinary incontinence.
Oh, so stress urinary incontinence could be caused by bladder overactivity with incompetent sphincter or incompetent sphincter to start with. These are the things I have on top of my head right now.
Okay. What is the actual mechanism because of which stress urinary incontinence happens?
Okay. Sorry, I take it back. So the stress incontinence could be either sphincter deficiency or urethral hypermobility. The stress incontinence. These are the main theories.
Okay, can you explain the urethral hypermobility theory?
So urethral hypermobility is the external sphincter is deficient, and the urethra is more into the intra-abdominal part, and hence it's not. I'm sorry, I cannot put it in words. I know what I say, but I couldn't put it in words.
Okay. So what will you do? This patient is not obese, I will say like 60 kg. She had 3 children born by normal vaginal delivery. Otherwise, menstrual cycle is fine. The examination definitely showed she leaks on cough. So, what are you going to do further?
Okay, so given that, so to start with, the conservative measures would include pelvic floor muscle training as per NICE guidelines, where it's recommended to be supervised. It should include 8 contractions 3 times a day for at least 3 months. It's known to have an efficacy of about 50 to 70%. I would also be interested in offering the patient the nice decision aid tool to decide among the other options if the conservative measures are not helping her symptoms.
Okay, what is the ICS standardized method for diagnose the stress urinary incontinence? You said cough test, etc. Is there any protocol from ICS?
I'm not sure.
Okay, we'll come back to that. And what other investigations you wish to do other than the pelvic floor exercise? Unfortunately, she's not having much improvement. You are reviewing her in 3 months' time. She's not having good improvement with pelvic floor exercise.
Okay. In that case, I would like to counsel the patient about further management in the form of surgical management. However, although I'm aware that the NICE guidance do not support doing urodynamics, in my practice, I'd like to do urodynamics to make sure to confirm the diagnosis that it's an isolated stress urinary incontinence.
Okay. The urodynamic shows it's isolated stress urinary incontinence. So, what is your next step?
So in that case, I will counsel this patient with a nice decision aid tool about the options I could offer, including urethral slings and Bursch-Coulson suspension. I will give her both options. I will also make sure to tell her about the success rate of both options, which is around 80 to 90%. Give her an idea about both, how it works, the possible side effects, including urinary incontinence or persistence of symptoms or urine retention around 20%. There might be also a chance of urinary tract infection, about 5 to 10%, damage to the urethra or bladder, 5 to 10%, as well as wound infection. I'd also counsel her about the possible side effects of the Bursch-Coulson suspension, including the vaginal prolapse, around 10 to 20%, urgency and damage to bladder, around 10%, and take it from there.
Okay. Before heading towards, do you have any medical options for her? Any medications?
Yes, I'm aware about duloxetine, which is non-serotonin and noradrenaline reuptake inhibitor. However, I'm aware that the NICE guidance is to not offer duloxetine as a second line and only offer it to patients who are not willing to have surgery or not indicated for surgical intervention.
Okay, that's good. And if the patient is not happy with the colpo suspension, what other options you have?
So the other option I forgot to mention earlier is the bulking agents, the bulkamide, which could be used. It has efficacy of around 50 to 70%. And I explained the theory, the idea of injecting the polyacrylamide injections submucosal in the urethra, which causes cortication of the urethra and could actually has efficacy of around 70% in presenting stress incontinence symptoms.
Okay. Any other options other than bulking agents?
Bulking agents, slings, and Bursch-Coulson suspension.
You explained about slings. You haven't explained much on slings.
Oh, so slings, basically the slings is the idea of slings are using autologous facial slings that are positioned mid-urethral. The idea is to strap the urethra, the mid-urethral area, and increase the resistance of urine flow. The most used one is the transabdominal facial sling, sorry, rectus fascia or facial lata sling. It's harvested through the finestyle incision. Yes, and the side effects include the urinary urgency and as well the urine retention in 10%. I'm aware about I'm aware that about the synthetic slings are offered in a few centers all over the UK, and this is after the Cambridge report. And hence, if the patient wants to consider the synthetic urethral slings, I will need to refer her to the tertiary centers that are still doing these procedures to be discussed.
Okay, good. Your time is over now. Good presentation. I can see the knowledge behind that. Just only the practice which will make things more perfect. Regarding the definition for stress urinary incontinence is defined as involuntary loss of urine on effort or physical exertion. Is a significant health problem worldwide, as we know. And regarding etiology wise, you can say if you the patient parameters, like it's also equally common in the white woman, and previous history of parity, obesity, previous hysterectomy or pelvic surgery, diabetes mellitus, a pulmonary disease like significant cough can cause, and less physical activity can cause positively. I mean, physical activity is positively correlated, so that may be one of the reason. And so you need to also say metabolic syndrome has a high chance for patients developing stress urinary incontinence. Mechanisms not frequently asked, but it's nice to know. As you mentioned, two mechanisms. One is urethral hypermobility, or also called as vaginal hammock hypothesis. The second one is weakness of the urinary sphincter itself, which is intrinsic sphincter deficiency. Second one is quite straightforward, but the first one, the reason is the compression of the vaginal hammock results in the intrinsic urethral sphincter also, and what happens is the urethra moves beyond the hammock, pulling the bladder along with that, so there is no appropriate cooptation resulting in leak. But your explanation is correct. And you can classify the SUI, stress urinary incontinence, into uncomplicated and complicated. That is one way of presenting and taking it forward. History, everything is fine. As far as the International Continence Society is concerned, the standardized way of evaluating cough impulse for SUI is female cough stress test in supine position with at least 200 to 400 ml of fluid in the bladder. 1 to 4 coughs. So you should bring this. There is no other way. So main things are supine position, 200 to 400 ml of fluid in the bladder, and 1 to 4 coughs. If examiner asks how will you say so much of fluid in the bladder, maybe you can do a bladder scan before the cough test. It is very clearly proven, as you mentioned, the supine position is not a good way of examining the leak. It's better to examine when the patient is standing, but this is only for standardization so that we are sure what is happening. So that is ICS standardization. Patient question is not very useful, especially for SUI. Post-void urine is very important, but again flow rate is not useful, and urodynamics are useful only if there is any reason like complicated SUI, not in general, not a pure SUI as you said, especially with nice guidelines. There is no need for any further imaging. Treatment wise, apart from pelvic floor exercises, you can say like weight management, like how we discussed.
Biofeedback.
Yeah, biofeedback, weight management, non-surgical weight loss improves urge incontinence in obese women, etc. In pelvic floor muscle training, there is a good stress on higher intensity supervised treatment. So you can bring those terminologies. Electromagnetic stimulation not useful. Electroacupuncture is useful but not widely followed. Regarding pharmacology, which you missed altogether, you can bring in both estrogen and duloxetine, but you can say that duloxetine is not much useful, keeping up with the nice guidelines. Nothing wrong in it, but bring those medicines so that if the examiner's key has those values or those bullet points, I wish you to complete them.
Yeah.
and surgical management is fine. Before heading to the surgical management, you can stress on the nice recommendations and scientific committee on emerging and newly identified health risk paper, which clearly says that any incontinence procedure should be performed by good expertise. Alternative surgical treatment should be offered, deal with the complications of the surgery facility should be offered, and a long-term follow-up should be offered. So you can stress a bit on shared decision making. This is applicable to any table, but you can understand why I stress it on SUI because of the previous multiple episodes of tape related complications. You can bring in the words like shared decision making, making sure the patient completely understands what's happening, patient has time to think about it, consenting, and documenting everything, facilitating the decision making, patient's opportunity to consider and think about it, those things. As far as surgery is concerned, open or laparoscopic corpus suspension, autologous slings, bulking agents, synthetic slings. Unfortunately, synthetic mid-urethral slings were taken to the last, as you have correctly mentioned. When you are discussing, you are almost about to miss the synthetic slings completely. Don't create so much of hatedness towards that. So you should bring the synthetic slings. You should say that it will be done in the tertiary centers with special expertise, and the patient should have a shared decision making opportunity. Otherwise, good discussion. Any inputs from anybody on stress urinary incontinence scenario?
I have a question, if you don't mind, Mr.
Yeah.
Danda. It's not in stress. Can we use the sacral neuromodulation in the urge incontinence?
Sacral modulation in urge incontinence, yes, we can do. Yeah, that was discussed last time. Yeah, only for stress, it won't be much useful.
Okay.
Yeah, so urgency, urge incontinence is the same pathway. Overactive bladder, they're all same pathway. Only stress urinary incontinence we are taking separately, and it won't work. Medicines won't work. Urodynamics not necessary if it is a pure SUI. So they will head towards that four surgical options of open or laparoscopic corpus suspension, autologous slings, bulking agents, and synthetic mid-urethral slings.
Yeah.
Good.
Can you just repeat that four options again, Mr. Dhanashekhar?
Surgical options.
Yeah.
The first one is open and laparoscopic corpus suspension. Second is autologous traditional slings. The third is the bulking agent. The fourth one is a synthetic mid-urethral slings. We are pushing the synthetic mid-urethral slings to the last because of the, like tape-related side effects in the past decade. But the YouTube video will have all the details, whatever I'm saying. I'm trying to match the material with the exact questions what we are discussing. So there's a lot of editing going on. So, but it will be good one. And
Mr. D, I was just under the impression that the least invasive things should happen first, isn't it? So bulking agent should be first, then mid-urethral sling, be it most likely autologous sling, and then corpus suspension. But my impression is that you can only do corpus suspension if you have urethral hypermobility.
Yeah, I mean, it works very clearly in urethral hypermobility because it is like for like. It exactly ticks the box. In essence, all these four options will help against both the options of both the problems of intrinsic sphincter deficiency and also hypermobility, all the four surgical options. But open or laparoscopic corpus suspension helps specifically in patients with urethral hypermobility, especially if they have a video urodynamics and it's clearly proven. And similarly, if it is an intrinsic sphincter deficiency, the best treatment is autologous or artificial urinary sphincter. That is the best thing. Here, what happens is your statement of going from minimalist to the complex procedures is not really suitable for stress urinary incontinence. The reason is, if a patient has bulking agent, just because it's a little bit lesser invasive, then the anatomy will be much more worse. Patient won't work out well, and then placing autologous sling in the same area will be a little bit more challenging. So in exam, you should discuss all the options equally, and patient can decide based upon the shared decision making. So don't give simpler one as a better option. Patient should be given all the four options and patient can choose. Similarly, for urgency, urgent incontinence, Botox, sacral modulation, P10 will be discussed almost in the same way. Don't think that Botox is less invasive and a lot of expertise are there, so let's do Botox. If Botox fails, we go for P10, or if P10 fails, let's go for sacral modulation. It's not like that, because P10 is less invasive compared to sacral modulation. But the problem is not many people are doing P10, while sacral modulation is done for more than 10-20 years now. We have a lot of evidence to that. So again, we need to keep all these three things. If the patient says, I don't want to do self-catheterization, I don't want any procedural anesthesia or something like that, then P10 may be a least invasive compared to the other two. Again, Botox can be given under local, especially in a woman by using a flexible cystoscopy or rigid cystoscopy. In a man by using a rigid cystoscopy if he tolerates. If it's an elderly man, they can tolerate, the urethra will be insensate, they can tolerate Botox with a rigid cystoscopy, if not with a flexible cystoscopy. So as long as we are taking the procedure into an outpatient setting, then it's better to offer them as a first choice. So outpatient setting, female Botox installation, male Botox installation if the patient is okay and tolerating. Definitely P10 is an outpatient setting, while sacral modulation is a definite anesthesia and inpatient theater setting. Sacral modulation, again, two steps. Make the temporary one with a skin implantation, see how the patient improves or behaves with the S3 stimulation, and then go for a permanent placement. While having permanent placement, we have now rechargeable batteries and non-rechargeable batteries, where the patient needs to have the procedure to change the battery every year. Rechargeable battery will be very handy for a patient who is quite good in handling number of times, etc., because it's rechargeable. If a patient uses sacral modulation quite frequently, they will expire the battery very quickly, and they may have to have anesthesia every third month to change the battery. If the patient has got significant health comorbidities putting high risk for GA every time, they will be better served by rechargeable one. So,
is this, are you talking about sacral nerve modulation or P10's batteries?
No, sacral nerve modulation. Sacral nerve modulation is the only one where rechargeable and non-rechargeable batteries comes into play. As far as the P10 is concerned, it is got two stages. The first stage is the office management by a trained urology nurse, where we do 6 weekly regimen. Patient has to come for all the 6 weeks, 30 minutes stimulation of the posterior tibial nerve, and then re-evaluate the patient in 6 weeks time to see how the patient coped well and improvement of the symptoms. And then patient will be given the P10 simulator to take home, and patient can do self-stimulation every second week or every fourth week depending upon the frequency of the symptoms. We have just started the P10 service in Birmingham Treatment Center every Friday. So if you are free, just drop in one of the Friday morning. Amy will be very happy to show you.
Okay. Can I just confirm, like with P10s, there is no implantable lead or anything. You just put a electrode or something. It's like an E3 electrode.
Yeah, it's transcutaneous. There are some concepts of percutaneous tibial nerve stimulation where there is a needle goes through the skin to stimulate the nerve, but transcutaneous or stimulation is percutaneous stimulation is the more commonly used. That's why the term P10. And for the patient to do in home, it has to be percutaneous. They can't do the puncture.
Okay. And just with sacral nerve modulation, because when you do the trial, the temporary sacral nerve modulation, is it improvement of 30% or 50% before you will offer a permanent implantable?
I mean, more the better. 30% is not bad, because these patients, the maximum efficiency is only 50 to 60% maximum. So if you take, I will put permanent only if it is 50%, means the number of patients receiving will be very, very low. It's more like how the patient feels. That's more important. Even with 30% improvement, patient may feel I can live with that. So if that patient is happy, then we can go for the permanent implant, because permanent implant is a bit of a commitment, isn't it? Because P10 you can discontinue anytime. It's not a big thing. Botox, if you stop, the nerves will, the new nerves will regrow, and that's it. So patients will be off in 6 months' time. So Botox will be weaned off. But sacral nerve modulation is a long-term commitment. We need appropriate C-harm, radiographer support, and it's very clearly proven that correct implantation on S3 with appropriate radiology guidance, the outcome is much better compared to just skin based landmarks and going without radiology or stimulating S2 or S4. They're all having very low outcome.
Just two, one comment and one a question. The comment is, I was under the impression, I think when I met the salesman for the SNS, that the battery lasts for 10 years. Is that correct?
That is like a rechargeable one where you don't have to change the batteries, and I don't think the same battery will work for 10 years, but you can easily recharge it transcutaneously. So there is nothing like surgery or anything. Patient can recharge in home itself, so the battery will work even lifelong, I will say. Yeah.
Secondly, if you've put the tine leads in and you've done, a permanent sacral nerve, and the patient wants to have it removed, how do you remove the tine leads? Do you just pull it out, or do you have to?
No, it will be like a surgery. So we need to open it out and make sure that there is the passage is made next to the tine leads, because tine leads are movable only in one direction. It will go towards the S3. When somebody pulling away from S3, it just like a rochet sutures. And so it's a bit of a dissection. It involves a lot of dissection to remove it, but doable. People have done.
Okay.
Mr. Anna, just one question regarding duloxetine. Should I mention it straight after failure of conservative measures, or only if I was told that the patient is not eligible for surgical treatment?
No, given the choice to me, I will go for conservative management pelvic floor muscle training, and if the examiner says no, patient is not improving with pelvic floor muscle training, I will mention that there are few options available before the surgical intervention. They are electromagnetic stimulation, not useful; electroacupuncture, useful but not widely available in UK; pharmacological management like estrogen and duloxetine. As far as the estrogen is concerned, it's very specific and useful only for SUI in postmenopausal women. We have missed discussing about the estrogen, and it could be quite a neoadjuvant if a patient is heading towards surgery. It will prepare the vagina nicely estrogenized so that the surgery will be, the tissue plane will be better. But systematic hormone replacement treatment, systemic treatment, just because patient is postmenopausal, is not useful for SUI. So, and then you can go to duloxetine. I will mention about duloxetine at least a couple of lines and say the NICE guidelines is not supporting it before going ahead for surgical intervention. Just create that same thread to follow. As I said, whatever I'm saying, I will try to share in the YouTube, so that will be quite useful. And then come back to me. I'm just trying to test myself to see how to present the best quality answers, both audible and also in the form of like a PDF, and let's see how far it's useful. Okay.
All right. Thank you very much, Mr. Anand.
Have a good rest of the weekend. Bye.
Thank you, Mr. Chandrasekhar.
Thank you. Bye.